I'm Hanna Dovbakh, Eurasian Harm Reduction Association, and I will chair this session, and we will be very lucky to have discussion. So if you have some ideas, questions about resilience and response, or resilience in harm reduction, and what are the secrets of resilient harm reduction, please take it in your notes, and we will be happy to have the live discussion between us. And before introducing our speakers, I need to say that this is an important question for all of us in the, let's say, occupied territories or territories which were colonized. And I will not, I'm not native here, so I'm not very good in saying the tribes and nations who lived here and whose land we are using and whose sky we are breathing. But being Ukrainian, I totally understand how important it is to feel your land and to be on your land. And I'm very, very hopeful that these oppressed nations will somehow regain this feeling of their land. Maybe it's not very political as it's written in there, but that's how we start this meeting, and I hope that it will be true for all. But anyhow, I believe that our meeting with values of harm reduction, bringing voice to people and to this land. And it's something miracle in connection with the people who grows in the land, generation and generation, and the land. That's why colony empires are falling, and that's our hope, that all empires will fall. Okay, and with introduction, what we will be talking about? We will be talking about the crisis and how we survive crisis and how we becoming stronger, more flexible in crisis, more resilient. It's a very specific term, but coming more and more important for us in the planning programs and in implementing programs. And unfortunately, fortunately, we are implementing programs, and as a community members and as a civil society, we are survivors. And that's so we are resilient to any crises, any challenges, new epidemics, new wars, new conflicts, new powers who are coming in power, like industries. In the same time, our governments are not so resilient, not so flexible, and not so open to changes. That's why I want to show you, if you want, from our region, from Eastern Europe and Central Asia, the fresh report on the guiding principles to effective and humane drug policies in Eastern Europe and Central Asia. And for us, it's important point, and author is sitting here making pictures, but for us, it's important to understand the challenges and to be resilient in policies. Today in the session, we will speak about resilience in policies, in practices, and being prepared to epidemic and to crises, which become a new norm, unfortunately. That's where we will, and if you will want to take some documents like this, we will be happy to share. And so with this introduction, and encouraging you to think of your recipe, your key for resilience, I will introduce Theresa Caruana. She is a scientist PhD candidate at the Centre for Social Research in Health, UNSW, Sydney. And her current research focuses on experiences of stigma in drug treatment and health setting. She has a history of working directly with populations experiencing structural disadvantages and lives in Lismore. This country I will not say sorry to miss. Please, Theresa.
So I want to pay my respects to the Widjabul people of the Bundjalung Nation, who are the custodians of the land where I'm going to be talking about and where I live. I also want to pay respects to traditional custodians of Nam, where we are today, and to any First Nations people who are present. I thank the flood-affected people of the Northern Rivers who shared their stories. So images that I'm showing in here are with consent of the subjects and photographers. There are no images of or directly related to the study participants, and pseudonyms are used in place of actual names. In February last year, northern New South Wales was inundated with record-breaking levels of floodwater. Most people in low-lying areas have raised houses. They're pretty used to floods up there, and they were expecting the flood to be about 1 metre or 2 under their houses, but during the night it rose to about 5 metres above street level. The speed and extent of the disaster was unexpected, and thousands of people became trapped in their homes or in their roofs or on their roofs. Emergency services were overwhelmed. Some houses collapsed and floated off their foundations. But miraculously, only 5 people died. There was an incredible community effort with people in small boats rescuing masses of people throughout the night. Whoops. And nearby towns as well, and some coastal areas also flooded. And even people who were on higher ground experienced damage from the storms. At least 8 of the 45 pharmacies in this region that dispensed opioid agonist treatment were completely washed out, and many others experienced damage. So my study is, I did some interviews with opioid agonist consumers and pharmacists about how they prepared for and were affected by the floods, including their efforts to maintain or reinstate the service coverage. I was able to do this because I was actually doing my PhD study and had interviewed a bunch of people the year before, so I was able to just follow up and see how, in that time, how they had gone with the floods, which was very lucky that I already had a relationship I could then go back and speak to them about for what some people was a very traumatic time. So here I describe difficulties that people were facing 5 months after the floods and reflect on how treatment services could be better protected in future disaster events. So 13 consumers and 11 pharmacists gave audio-recorded, semi-structured interviews of about 20 minutes, either in person or by phone. And in this presentation, I've picked 8 of these to present as illustrative case studies. I'm using a frame of interpretative phenomenological analysis. And the cases that I selected, they were because they demonstrated the complexity of issues that people faced, the efforts that pharmacists made, and also to contrast consumer outcomes. So I'll start with the pharmacies. So Mary's pharmacy had been run in her family for generations, and they'd been through many smaller floods. She prepared by lifting all of her shop fittings and stock to the second floor of the building, which took her 2 days. By the time she was finished, she was trapped inside by the floodwater and had to be rescued by the state emergency services. While she was there, she had used her phone to photograph all the pages of her opioid treatment register and all the customer scripts. So she had these records on her phone and was able to send these through to the public clinic. There was a nearby public clinic that was out of flood. And by doing that, her customers were able to go there and get emergency doses while her pharmacy was out. Luckily, the floodwater didn't enter the second story, so when the water receded, she was able to clear out the shop, and within a few days, she was actually dosing some of her customers at the door. So the shop was gutted and she reopened it within a week. A month later, she had to pack it up again because a second flood came through. By that time, she was just able to hose it out, and she reopened the next day. So 5 months later, when I spoke to her, the pharmacy was operating just in a small section of the shop and building work was carrying on behind. She was actually really happy with how she managed and said that, but she did say that people haven't stopped yet. People like us are still running and chasing, and I don't think it's all processed. So Adam had just taken over his pharmacy 6 months before the flood. He had packed all the stock high, but the floodwaters came in and the front wall of his pharmacy collapsed. 2 safes were stolen. They contained litres of methadone and some Suboxone. He lost all of his paper records, including the opioid treatment register. So teams of volunteers came in and helped clean out the mess. He was able to set up a temporary shop next door pretty soon after. But his 60 opioid treatment customers went to the public clinic to be dosed there. And one of them spoke to me and said that in past floods, the previous owner had faxed all the records to the public clinic to enable that to happen. But this time, when he got to the clinic, there were no records. So he was given a starting dose of 30 mils, and it took 2 weeks to titrate him up to his prescribed 190 mil dose. So consumers then transferred back from the public clinic slowly back to Adam. They had to obtain new scripts in the process from their prescribers, and there were fewer now because many had lost their homes and were in emergency accommodation elsewhere. Adam said that had I known what was going to happen, I would have hired a truck and got every bit of stock out of there and saved ourselves $600,000. So Will had a pharmacy in a residential area on a ridge above the floods. He was overrun with all manner of customers and stayed open overtime to service them in the weeks that followed. They included many on opioid treatment, and he gave discretionary doses to those who, without scripts, by using his clinical assessment skills, obtaining information from the public clinic when he could, and sometimes extracted information from the government's online portal, My Health Record. He prepared doses for people who were in the nearby evacuation centres, and they were limited to daily dosing because there wasn't sufficient security in the evacuation centres to allow them to have takeaways. Will soon ran out of stock, and he had to arrange with the state emergency services to have some helicoptered into a nearby sports field. Reflecting on that time, he says, "It was a bit illegal in terms of dispensing Schedule 8 medications, but we had to. We only had dosing information of where they'd been, what dose they were on, and we were able to sort of provide that on a day-to-day basis just to give them some medication, because a lot of them had missed out." So Brendan became stranded in his pharmacy when the village around him flooded. He stayed there for a week with no power, sleeping on site, and servicing queues of customers who were arriving at his door using torchlight. He recorded everything manually, including handwriting medication labels. He did have a paper opioid treatment register, so all of his customers who were able to access him at the pharmacy were looked after fine there. As stock ran low, he had to also limit takeaways, and then the co-owner, Nathan, organised supplies to be delivered by boat across the floodwater. They were also flooded a second time, and when that happened, the co-owner, Nathan, stayed this time, and he had to stay for 3 nights there doing the same thing, doing everything manually. They were also visited, there were a number of people in that village that would go to a public clinic elsewhere, so they used their clinical assessment skills to provide doses to those customers. They only had one mobile phone that ran out. They sometimes could talk to the public clinic. It was running out of power a lot. But they did an amazing job, and Nathan said that a lot of those customers we were able to assist were truly, truly grateful. So now we'll look at the experiences of opioid agonist consumers. Andy lived near the coast and was rescued just before the flood destroyed his home. He was at an evacuation centre for 4 days without Suboxone, and he took the first available bus to the main public clinic. He waited in a queue of about 100 or so people, many of whom had been affected by the floods and were distressed. It took hours to be seen, but he was able to get his dose. He slept on a friend's couch so that he could continue to visit the clinic each day, but he wanted to be with his Bunjalung community, saying, "My family was trapped on the mission for almost 2 weeks. I was worrying about them." The clinic then was able to transfer him to a pharmacy that was nearer to them, and he was really happy with how all this was arranged. And he was now staying with his family and waiting for other accommodation to become available, and was back at work. So Ryan's home didn't flood, but his pharmacy and his prescriber's clinic were both destroyed, and they were uncontactable. He needed a dose of methadone the next day and went to the public clinic, but was told they didn't have any records of him. He had the personal mobile number of a previous pharmacist who had moved out of town, and he was able to drive there, and that pharmacist gave him 2 discretionary doses. He then sent a photo of an old takeaway bottle to the public clinic, and a prescriber there wrote him a script for a week based on that information. When that week ran out, he got in contact with them and they said they couldn't reissue the script because they still hadn't had any contact from his prescriber. Ryan then contacted the pharmacist who had helped him, and that pharmacist actually advocated on his behalf, saying he knew who he was and this was his dose, and he managed to get a script for another week based on his pharmacist's advocacy. And Ryan said those weeks were incredibly nerve-wracking because he was on a high dose that helps with his often severe symptoms of anxiety. He praised his pharmacist, saying that without his intervention, I was basically going to be left high and dry. So he's now decided to reduce his dose with the aim of coming off treatment, as he doesn't ever want to be in a situation like this again. So James is a carer for his elderly parents in a small town that had minor flooding. A nearby creek swelled and cut him off from the town centre, so he waded through the chest-high water to get to his pharmacy. The pharmacist had called his prescriber in advance to authorise extra methadone takeaways, and he prepared these along with James's parents' medications. The pharmacist taped up plastic bags to make them waterproof, and James waded back home. Over the next day, stormwater flowed down their hill, entering and damaging their kitchen, but he and his parents managed to stay well until it passed. He said, "The pharmacist gave me a month's supply because we didn't know how long it was going to last. I came back home and I didn't have to worry about it anymore. I just had to deal with, what was going on." So Tony and his partner were living in an inland village, and he was dosing at the small public clinic there. Stormwater created landslips and washed away roads, preventing staff from accessing both the clinic and the town's pharmacy, which were unable to dose consumers for 4 days. Tony experienced withdrawal symptoms, but was unable to leave the area or get any assistance. He tried to source methadone or other opioids illicitly, but had no luck in this either. He said he just rode it out, making sure that he slept and ate well. On the 5th day, the clinic opened, and Tony said when he got there was people from all around town, and most of them were quite sick. In the time since, he's purchased a caravan with his partner. It's parked outside a block of gutted flats, and they pay a little rent to access a garage with a toilet. He transferred to a local pharmacy and was happy with his situation, as it's cheaper and more convenient, despite being in an active disaster recovery area. So the pharmacists and consumers affected by these flooding and storm events experienced extreme challenges in maintaining or regaining opioid treatment services. A number of consumers described how needing to get their dose, and often waiting many hours each day for this to happen, prevented them from being with their family and friends who were in crisis, and that this was very frustrating. However, many also showed great patience and understanding under these trying circumstances. It is clear that the primary public clinic played an essential role in coordinating emergency care by communicating directly with pharmacists and prescribers, often via their personal mobile phones. There are also many pharmacists that went to extraordinary lengths to provide essential services to their community during this time. There is a need for secure information sharing systems to enable care continuance in an emergency, and for state assistance in servicing consumers if their providers are out of action. Options here could include telehealth script reissuing, mobile medical services that include opioid treatment prescribing, and emergency services support in helping pharmacists access essential medication stock. Pharmacists' efforts in providing advanced takeaways or discretionary doses reduce consumer hardships and distress, and program regulations should reflect and support this. A number of pharmacists plan to have electronic records saved to a cloud that can be downloaded and shared in emergency circumstances, and those in more rural locations are looking to have generators and satellite internet installed in case of power or network failures. Pharmacists who had been through the floods before were more prepared, and their consumers had less treatment disruptions. Newer pharmacists could be given the opportunity to learn from these experiences and develop disaster preparation and response plans. Communicating emergency processes is crucial, as many consumers felt unsupported and forgotten in the midst of the crisis. A centralised phone and online support service could assist in remotely organising emergency doses at alternative pharmacies or sites, or in organising secure deliveries in situations where they have no other access. Thanks.
Thank you very much, Theresa, for sharing these stories. I felt like I understood what were challenges, but in the same time I'm a bit jealous. In one point, pharmacists were thinking about patients and we're advocating for them to make a bit illegal action to give the opioid substitution treatment. I would love to see pharmacists like this and opioid substitution treatment operated not through one clinic in the 400 kilometers from the place people living, but in the village. That's amazing stories, and that's how social science could work. You feel like you've been there rescuing some people. Thank you. We have a moment for questions. We don't need to rush. Please, maybe you have some questions or observation about this story. Yes, please. We have two questions, first Dan and then here. You could say who you are and then share.
My name's Maureen. I'm from Sydney. So I heard all about the Lismore floods when they were happening in the rest of Australia. We couldn't believe what was happening over there. You just mentioned my health record. Do you think that was any use or could be used in future to help in these situations?
It's an interesting one. It did work. One pharmacist did use it, and he could see who the prescriber was just to give him confidence to then give that person doses because he had no other records. But not everybody's registered on it. There's privacy issues. There's a lot of reasons why people wouldn't want that sort of information registered on a centralised government portal. So I think there is a lot of benefit, but I don't know that then it would necessarily be supported by everybody. There might need to be alternative strategies. And that's where pharmacists actually sending their records directly to the clinic, that still felt a bit more private. So the idea of having it downloadable or faxing, that sort of mechanism, if that could be shared within the select group, that might be a better way than having... Yeah, it is tricky though, because if the flood was bigger and there was no records, the public clinic went under, those sorts of things, in that situation you probably would want that government portal. Yeah.
Thank you. I would add from our perspective, and then we will come to other question, with the governmental registry of people who use such services or are using drugs or treating drug dependency. In post-Soviet countries, we face it's as a hugest barrier for services and a hugest stigmatizing factor to not to let people to have jobs, to not to be employed, to have education, to drive a car. So as always, such a registry, it's not only about, but in the state of emergency, maybe Nadiia will touch upon this, but national authorities who have this registry of people who receive RT and receive OST, they were able to send health data and prescription even abroad to the doctors by request of patient or doctor for them to start from the same dosage. So it worked like this in case of Ukrainian centralized database of patients. So just example from other crises. Yes, please, your question.
Hi. I wanted to ask if you talked to anyone who ran any of the evacuation centres and whether they had any policies around keeping certain medications on site and as part of their practice.
Maybe we will take one more question from the lady and then two questions. Yes, please.
I'm Ruth Phillips, a harm reduction worker in Coffs Harbour Hospital. We had the same storm, but we didn't get the flooding because we were, 2 hours south, 2.5 hours south from Lismore. I was just thinking, and when you were talking about the My Health, this is just a comment, the baby books that the people have, would this... When a baby's born, they have all the information on the baby and if there's any medications or what. Could the client be given their own information so they can actually keep that information? And and then at least they've got what dose they're on, the doctor they see, all the information they need, so they can actually then take that to another pharmacy that they can actually access, or to the public clinic. I don't know if that would work, but it's just an idea.
Yeah, some of the pharmacists even spoke about how electronic prescribing would be really helpful in this situation because they would have that record. But in our state, it does not happen for opioid treatment at this point in time. But hopefully that is something that could happen in the future, and then that would make it. Yeah, I don't know, to me it sounds like there is resistance to letting opioid agonist consumers have their own records that they give to. I don't know that it's a barrier. I think pharmacists...
and the question about evacuation services.
Yeah, it is a good idea though. But then there is a situation where there were people who lost absolutely everything and had the clothes on their back and ended up at an evacuation centre. And in those situations, they did apparently sometimes have a medical person on site, but the evacuation centres were so overwhelmed with people, hundreds and hundreds of people, more than they could house, that I think, security was a massive issue. I don't think there was secure medication storage available on site from what I heard, so that's why people weren't able, even if they did have scripts that were active, they couldn't even get takeaways. The other issue is that because the floodwater surrounded the area, all of the services were worried about running out of stock, so almost everybody limited it to daily doses after the flood happened.
Okay, we're taking one more Australian question, I guess. And then moving to Ukraine and Eastern Europe. Yeah.
Hi, my name's Blue. I lost my place in the floods in Lismore and was one of the people that left with everything on my back and through a window on a boat. And I know for some diseases and whatnot, there's medical bracelets that people wear that will say things, or my partner. When she got on opioid, and she gave me a business card that says the dose that she's on in case she ends up in hospital or something and they need to know and she can't say it. So I understand why these things wouldn't be sufficient to get in a regular circumstance, but it's a shame that in crisis, if there is the amount of medication there, that they can't be used, but community did really come together and people helped each other out a lot, which was, really great to see at the time.
Thank you for sharing. Come and talk to me later too. Yeah, that's the other side of this story the flood was completely 3 metres higher than anything ever predicted, so everyone was caught unawares. And a lot of the consumers who spoke to me actually minimised, even if they'd missed doses for days because of how big the disaster had been, and they were just grateful to get some assistance. The other side of it was there was many consumers that had been dosing in pharmacies for years and years and years, and having to go to the public clinic and be really visible and stand in the sun for hours was a really difficult thing for a lot of people too when they'd been really private. There was people that worked in health services in the area and didn't want that part of their lives to be exposed, but were forced to stand there in a big queue. So there was a lot of issues that came up around it. But I have so much faith and love in the Northern Rivers community, and I'm sure the health services, everybody at the moment is talking about this stuff. I'm kind of presenting sort of what happened, but hopefully in the future they'll have a really good plan for dealing with this sort of situation. I think that there's a lot of people thinking around those sorts of issues.
Thank you for this discussion. I guess it's a good start to think what make us resilient and help to survive and keep the dignity in this surviving. And I'm moving to Nadiia Iangol from Alliance for Public Health, and actually Nadiia is working for more than 15 years in HIV and hepatitis C response, and she will tell a story on sheltering actually and housing during the crisis caused by Russian aggression. Nadiia.
Hello, everyone. And just I'm really thank you to talk about Ukraine, to talk about harm reduction services in war condition in Ukraine, and just share our experience in this difficult war conflict with Russian aggression. I woke up on February 24th and like it's usually pick up the phone and understand that my life is changed forever. And I think that we can say that the life of all Ukrainians were simply divided by line, like life before the war and life after the war, after the full-scale Russian invasion of Ukraine. 15 million Ukrainians have left their homes and become internally displaced persons or refugees, and over than 1,400 healthcare facilities have been destroyed or damaged, and damaged by Russian invaders who are committing war crimes against the population, denying civils access to vital services and treatment, torturing and killing people. People living with HIV, clients of our project, social workers, also physicians are died during this war and died every day. In the pictures, you can see harm reduction offices in Ukraine, in Kherson, in Nikopol and Mykolaiv. It's all the cities close to Russian border. During the war, we greatly expanded the packages of services, and for like basis minimum package services that our clients received before the war, before the COVID time, we just also added like humanitarian project that included shelters, food kits, certificates to buying clothes, foods, buying a mobile communication. Also, we just added very specialized consultation. We offered our clients money for rent houses, rent flats, and also we organized some space places for social workers and for our clients. And I want to add that we organized like humanitarian convoys. It's for transportation of humanitarian aids and evacuation our clients and other civils, delivery RT, PrEP, or AT treatments in order to prevent interruption of treatment and prevention for our clients. Also, during the situation, we are thinking not about to keep the services. We're also thinking about to bring something new to Ukraine, like that another country have. It's an innovation project. We, during last year, we provided long-active buprenorphine in Ukraine for our clients, and also we advocated for whole year, like a new approach for PrEP. It's long-active PrEP, and finally this autumn we will have cabotegravir for 100 clients, but at least it's a good start. And also we really moved forward with online services. We organized a big Help Now hub that now working more in the like 5 countries, but provided services in 47 countries for our clients who just moved to like refugees to another countries with their family. And also we're thinking about basic safety for our clients and for the services providers. Like we're trying to equipment some offices in we organize some basement for shelters. We also providing bulletproof jackets for the social workers, and we provided like first aid trainings for our social workers because it's for most of them it's like additional quality to work in such condition. Let's quickly explain about our humanitarian project that we just added to our services. That this project is significantly expanded the list of our key population, and in addition to the populations that are mostly vulnerable to HIV, assistance is also provided for internally displaced persons and family in difficult life circumstances, elderly people, and people with disabilities. And during this project, it's usually our covering of harm reduction programs for the year, we're about 300,000 people. But during the last year, we're covering more than 1 million people. It's our clients, it's the members of their families, it's children, it's like all people that just stay in some places where we just transferring humanitarian aids and take them and keep them in our shelters, provide them their psychologist help, and also. During this humanitarian project, we organized 25 safe spaces, shelters, and it was not only in safe areas of Ukraine. It also was very close to the border of Russia, because some of the people just in different circumstances need to stay there just to provide services, to work, to live. Want to give you more details on walkabout shelters, and fundings for the first shelters was already in 1 month, and we organized I want to tell that each organization just have shelters for their clients, even for 1 hour, sometimes for 1 night, but all of them just wanted to have more facilities to provide shelters for more safety and for more long time. And we're trying to cooperate with government, with not working organization, because we have budget, we have money, but we need premises, we need some conditions, we need honestly safe places. And our work was creation some stationary places for living. We provided food, transportation services, and we, on all our shelters, just support multidisciplinary teams. It's for not only social workers and medical, it's also psychologist support with experience working with our vulnerable people. And our main purpose of our organization is to prevent HIV, and we have case managements who are strongly have connection with all our program, harm reduction programs, OIT program, ART, because if the people can't move, we just organize good connection with mobile clinics, with transferring, and in these shelters people can receive all services. Also, in this war, we just opened more widely these groups of raped our clients, general population, and we provided a comprehensive package of services for the victims of rape. We covered, I already mentioned, like 25 shelters. It's only our organization, but in general we have different donors, and I think that it's more than 100 shelters in Ukraine for our key population, because we have very big coverage of our clients. But sometimes we receive like some of the request, like we need only beds, or we need only food, or we need like some household equipment, like buying some kettles. Sometimes it was generators. So we just provide also like such helps, and for shelters even that we never budget or never equipment. It's like also was in our duties. And we also open some shelters in countries that receive our clients, our people. It's Poland, Moldova, Germany, and we have like at the beginning it was like hub a hub for just to receiving ART, OAT treatment, but after just we keeping all the help, like food, clothes, facilities for children, because it was like not about our small harm reduction program. It was like a big program for our clients and other people. And from the first days of the war, our organization just made the decision to involve mobile clinics, mobile ambulatories that were in balance of our organization, and to organize the work to meet urgent humanitarian needs. And we all our drivers were volunteers. We have 32 people who just was ready to go to war conflict territory and just to provide the humanitarian needs. And honestly, sometimes in some days we were only one organization who just went to their cities, to their villages, and in way back we took our clients and other people, and mostly like 600 civils we have evacuated from zones of conflict. Just want to pay very big attention for the basic safety of our service providers. Of course, we received every day just some requests that we need this, with this need, we need like surgeons or treatment or like this, but we're also thinking about some safety work condition and delivery in safe our services. And we organized we buy in for all our social workers bulletproof vest, and for some of them we organize like bicycles with thermal bags, just to be sure that sometimes it's like shortage of fuel or like challenges with transport, like transport collapse. Like we had such conditions for providing services. And also just trying, it's very complicated, very difficult, because most buildings in Ukraine not ready to receive shelters every day, because it's we don't know exactly what it's coming for us tomorrow, and it's impossible to keep a basement of all buildings, but we try to organize the shelters, try to keep them really more stronger, because people still there and services still provided. Yeah, and just like to come back to harm reduction program, identification of new case of HIV infection among vulnerable people is the most purpose of our organization. And despite disruption of the healthcare infrastructure, during the last year, 156,000 clients from among key population passed HIV rapid test in different models. It's like with self-testing, mobile clinics, providing in stationary offices, also outreach routes, and it was really good results for detection, because we had like more than 7,000 confirmed positive cases, and it's about 57% from all detected cases in Ukraine. In Ukraine for the last year was about 12,000 cases, HIV positive cases. And big success we just made also for OAT programs, because we just reached the major milestone. It's about 20,000 clients received this service in Ukraine, and it's the biggest number of patients among all countries of our region. It's Eastern Europe and Central Asia. And for last year, it's more than 2,500 people started new in this program. I want to just also like tell you small, not success story, but small story about Kherson. Kherson, I think that everyone knows the city, like Bucha, Irpin, it's Kherson. Now it's like half of the city, like under Ukrainians, half of the city is still under Russian control. And after the deoccupation, access to treatments was restored for 128 patient for this OAT program, and because during the occupation the site was brutally closed and all the treatments of the medicines were destroyed, and like following the occupation, we just opened. It's for the Kherson. It's really small amount for receive this treatment, but it's still like success, because we reopened. We just again there, and the clients like can receive this help. Yeah, also just not here, but I want to mention about PrEP treatment for our clients, and during the war it was increasing for more than 30%. From the 6,000 now we have more than 9,000 people for PrEP, because it's like raping, it's a dangerous situation, it's like people sometimes, yeah, we're just covering, but sometimes they don't have access for the clean surgeries and any situation. But our clients, like for the last 15-20 years, our work just very informed about how they can get HIV and everything, and the PrEP program was really successful for the last year. And just if we want to, it's not lessons like lessons, yeah, but it's lessons learned during the last year of our organization, maybe, or like me, like a manager of the program, that there is no standard package of services. Services change radically during the emergency situation and different emergency situation. And you, in these cases, need to have contingency plan that we already familiarize ourselves during the COVID time. So in any case, everyone just need to think in about plan B for the, maybe in the country level, in the NGOs organization and Ministry of Health, stakeholders, and even all of us, because just our case, it's my personal case. I just live like 23rd and 24th, it's like different lives for me, and this is I need to live for all my life now. And also just good lessons to think about your staff, because of course some of the emergency preparation started like at once, but you need to be like ready to cover not only like one person can start it like 5 person at one day, yes, because you just need to care about if it's a social worker to thinking about his family at once, because nobody just can do their job just if their children or their parents like in some not safety conditions. And like also good lessons for us, it's working communication. I mean, COVID, it was good example, but what just show us that if you just lost everything, you just need to write about this. You just need to voice your needs, just asking this help, using all the channels like internet, phones, friends, everything. Because sometimes we just only thinking about something, and just after voice this, and the next step it will receive it, because some of the people just in such situation ready to share this help. Sometimes they have special big businesses, small businesses, like everyone just ready to help you. And a big part of victory, and the next lesson, it's gratitude. And I would like to take this opportunity to express my admiration and gratitude to the incredible works of partners organization, of social workers, of NGOs, civil society, communities, doctors, nurses, because like these people are incredible. We're just here because we are people. We just do our work, and it's everything that we manage, we honestly achieved together. And many thanks, of course, our government, our UN agencies, international donors, and just the biggest and huge thanks to the armed forces of Ukraine, which honestly protect not only Ukraine, but also the fundamental principles of peace, freedom, sovereignty, and dignity of, I think, that all of us and each country. Thank you.
Thank you, Nadia, and thank you to all the team. It's really why the award went to Ukrainian organizations, all Ukrainian organizations. You could not select one, because it became such a huge solidarity. And as we recognize all clients and beneficiaries and community members, if they have at least one telephone working, they could survive in occupation. They could survive during this crazy evacuation processes. They could find treatment because they are connected. And actually, from my lessons learned being in some, telephone coordination and bringing some humanitarian help in Ukraine, I need to say that well-organized and well-mobilized community and civil society, that's the key. Doctors and nurses are heroes. Not all, but majority, they really, in occupied Kherson, under criminal liability of Russian repression law, they could give methadone for clients till from February till May or June. I don't know how they did this. It's just under bombing and under threat of being killed for distributing drugs by Russian soldiers, having Russian soldiers in the street. It's just incredible solidarity, but for me, key point is connections and mobilization, not as a literary mobilization, as we call it in the community, peer support, empowerment, but it's real connected communities within Ukraine around the region. So that's for me the key. But also as funding for HIV response, hepatitis response, were in the hands not governmental officials but civil society. That gave the flexibility. So civil society as PR of Global Fund, PR of other funding, it gives flexibility because governments needed, even in a crisis, they needed I don't know how many months to agree any regulations and money issue and all of this, and they still not there, even despite all commitments. So this flexibility in funding, that's what I would need to add to Nadiia. We have some couple of minutes for questions or comments on Ukrainian situation. We have even more. We have Zhenya and Lena here who could comment. Yes, please.
I'm just wondering what happened to the illicit. Thanks. I'm just wondering what happened to the illicit drug market in Ukraine. Could people access drugs anymore? I'm assuming it probably dried up. And in that case, did you get even more people seeking treatment?
You have an answer. Yes,
Sorry, Nadiia, that was for you. I'm wondering if people could still buy drugs or not.
Yes, it's still drugs in Ukraine, but also just I mentioned about PrEP program in Ukraine and OST program. It's ridiculously raises because people, some of them lost this connection, some of them still have, and of course it's under control now. Before was organized by government, by police, by some organization, and we tried to honestly for this reason we also increased naloxone program because it's still some of the region still needs them and just asking us a donors organization to provide them, but this.
Drugs thing is not researched yet because the war happening, and of course there are some stimulants, and we expect as a drug policy experts in the region, we expect changes in drugs thing, because it was usually opiates and stimulants use, and it was somewhere in between. It was moving to stimulants as a recreation drugs. But now with the war, of course, there are opioids as a painkillers, and you know from American histories with all these stories with drug use and veterans, and we are somewhere in a very huge boom for the whole region. We don't know what will happen, but of course, illicit drugs are all around. But with the opioid substitution treatment, what helped that all international community and National Center for Public Health, they were very fast. They were trying hard to procure OST and to feed the market, even for those who never been on OST, and for those who received OST not being registered in a drug registry, avoiding this and buying OST in pharmacy in some gray zone, which is not OST, but still somehow. And this balance was kept with the state service, and that was very good
Mm-hmm.
flecxibility. And we are keeping an eye on the drug scene, and it will change all around the region because it's affecting all the region. Ukraine is big. And it's a huge topic. If you will want to reach out to Nadiia, to Lena, to Zhenya, to me, we are ready to share because that's huge experience we all learned. It would better to not to learn this, as always with crisis. So now we have chance to move to Myanmar, and actually our distinguished Aung Naing I guess it's something around, a health director of Asian Harm Reduction Network with 15 years experience in harm reduction, will share his experience in Myanmar of crisis. And actually, it's a pity, but the crisis is a new norm, not only in the Eastern Europe and Central Asia, but in Southeast Asia. Please, floor is yours.
Thank you, Chair, for the introduction. And firstly, I would like to pay my respect to the traditional owners of this land. Good afternoon, everyone, and welcome to my presentation. First of all, let me thank you for coming here today. So as you can see on the screen, I'm representing both Asian Harm Reduction Network Myanmar and our sister organization, Best Shelter, to share our best practices and how we overcome our challenges during COVID-19 pandemic, and also the profound political crisis in Myanmar, and how we transform those challenges into opportunities, and how we convert evidence into practices for harm reduction in Myanmar. And most importantly, I'm representing the brave frontline prevention workers, outreach workers, and healthcare workers from HRN and Best Shelter. And I also would like to acknowledge their hard work and their tremendous effort in providing harm reduction and healthcare services in the most conflict-affected areas in Myanmar, especially the northern part of Myanmar. Without their hard work and effort, I cannot stand here and share our experience with you all. So up to now, it is estimated that it is more than 3,000 civilians have been killed since February 2021 because of the civil conflicts. And sadly, we don't get that much attention from the international community. Like other countries, Myanmar is exceptionally hardly hit by the COVID-19 pandemic. And this figure shows the COVID-19 situation in Myanmar up to 12 April 2023. Myanmar has more than 600,000 confirmed reported cases and almost 20,000 death cases, according to the WHO data. However, this data is likely to be underreported because we still have a lot of unreported and unconfirmed COVID-19 cases. And the virus was confirmed to have reached Myanmar on 23rd March in 2020. And at the time, the civilian government rapidly implemented containment measures and public health measures, public health response. And we can see that almost there was no mortality during the first wave of COVID-19. And however, in the second wave, we can see that there is slightly increase in the COVID-19 cases and a few mortality during the wave 2. And in February 2021, Myanmar confronted with a profound political crisis and civil disobedient movement, mainly led by the healthcare professionals, causing the near collapse of the country's entire public health system. And we can see that the COVID-19 reported confirmed cases and mortalities were spiked during the July, August, September of 2021. Prolonged conflicts, COVID-19 related restrictive measures such as lockdowns, which increase barriers to access harm reduction and HIV-related healthcare services. And drug use is a rural phenomenon in Myanmar. Asian Harm Reduction Network and our sister organization, Best Shelter, we implement comprehensive harm reduction programs in a midst of so-called sensitive hotspots with conflicts, jade and gold mining, poppy production, extreme poverty, high disease burden such as HIV, TB, hepatitis B, C, and other infectious diseases, and also cross-border drug trafficking and drug-using labor migration. And our projects are mainly located in the northern part of Myanmar. This is northern Shan State and Kachin State and Sagaing region. So Kachin and Shan State, which have a long history of severe conflict between ethnic armed groups and the military, but Sagaing region, which is an emerging and one of the most conflict-affected areas in Myanmar after February 2021. So, what we have done to tackle those challenges during pandemic and in conflict setting. We recruited local community people and also the owners of the grocery shops from the villages in our project sites. And we recruit them as community prevention workers and NSATM owners. And NSATM is a needle syringe automated taking machine. This is the photo of our needle syringe automatic taking machine box. We put those needle syringe boxes in the village, in the grocery shops, so that the period they can access to the clean needle and syringe 24 hours a day, 7 days a week, without worry, and it is free of charge. And we also empower the NSATM owners and also the community people to have more understanding on complex nature of drug problems. And we also enhance the secondary needle distribution through dealers and innovative community-based NSATM at grocery shops. So despite the political crisis and COVID-19 pandemic in 2021, our needle distribution has increased from 16 million in 2019 to 18 million in 2021. And the secondary distribution also increased from 10% to 26% in 2021. And one of our donors, who was previously very reluctant to approve this secondary distribution, but because of the travel restriction of our outreach workers during lockdown and crisis period, and finally we got the approval and green light from the donors to fully implement such kind of model in all of our project sites. And as for Medicare care, AHRN initiated ART satellite site model in Key Population Service Center or drop-in center in 2018 in close collaboration with National AIDS Program. ART initiation was implemented at public sector, and so the clients, they had to go to the public health facilities to initiate ART. And then ART maintenance, care and support services, adherence support, patient tracking, and follow-up, which are done at Key Population Service Center and community-based outreach mobile. While public health facilities were not fully functioning because of the political crisis, we advocated with a local national AIDS program, and we got the opportunity to decentralize ART initiation and dispensing through the satellite clinic model in our Key Population Service Center, which greatly increased the access of ART among period because the clients, they don't need to go here and there for getting ART, and they can get the one-stop shop service at our Key Population Service Center. And we also advocated for the multi-man dispensing of ART, and which can also improve treatment access and to reduce the risk of COVID-19 transmission, which can occur at the frequent exposures and crowded facilities. So people receiving ERT increased from 1,700 in 2019 to almost 3,500 in 2021, and which is almost double of 2019. And multi-man dispensing of ART for 3 to 6 months also minimized the frequencies of clinic visits and unnecessary contacts. The clients are more productive because they don't need to come to the clinic frequently, and which can also bring down their financial barriers. We also assisted the National Drug Treatment Program in methadone initiation and dispensing at public health facilities, because at the time methadone is allowed only in the government facility, and we could not operate outside the government facility. So since the first wave of COVID-19, we set up hand washing stations and social distancing and all other infection prevention and control measures at the methadone clinics. And at that time, the National Drug Treatment Program also relaxed the restrictions on the methadone take-home doses up to 28 doses for clinically stable clients, regardless of their treatment duration. And when the public health facilities were not functioning because of the political crisis, we advocated with the National Drug Treatment Program, and we could bring the methadone initiation and dispensing into our key population in service center, and which is closer to the clients. So AHRN initiated the KPSC or DIC-based methadone initiation and dispensing, and which greatly increased the uptake of methadone. So in 2019, the number of people receiving methadone was around 5,000, and which increased to 8,000 in 2021. And in 2019, almost 21% of methadone clients they receive take-home doses, but in 2021, up to 83% of methadone clients they receive take-home doses. And the methadone retention, we can also see that it was greatly increased in 2021, up to 83%. So scaling at methadone take-home doses and decentralized methadone initiation and dispensing to the areas where clients, they are more accessible, they are more comfortable, and they feel it's safer to come, such as our key population service or drop-in center, which could improve the methadone uptake and also improve the retention. In conclusion, community-based harm reduction activities and secondary needle syringe distribution play a major role in prevention of service interruption due to roadblocks or travel restriction because of COVID-19 lockdown and or conflicts. And we also need to build the capacity of local community to create an enabling environment and provide quality healthcare and harm reduction services. It is also important to decentralize and integrate services, and multi-man dispensing of ART also could overcome the obstacles in enrolling into HIV treatment and care cascade. And relaxation of methadone take-home doses is also associated with increased methadone uptake and improved retention. So despite profound challenges, both AHRN and Best Shelter could turn obstacles into opportunities and problems into solutions to uphold harm reduction program in Myanmar. So last but not least, I would like to thank to our donors, Access to Health Fund, Global Fund, and USAID for their general support in harm reduction implementation in Myanmar. And this is the end of my presentation, and thank you for your kind attention.
Thank you very much, Iangol. Do you have any comments, questions? We all been in COVID crisis, and yes, it was ages ago. In my feeling, it was before the war, as our grandmother saying. It was before the war. But maybe you have your recipes, your key findings, what help your programs to be resilient and to survive and help people to survive. That's the good moment just to share the thinking, to share reflections, what may be this key point to include in contingency plan or to key point to include in our surviving in the crisis. Yes, introduce yourself.
Thank you. I'm Olena Kucheruk, also from Ukraine. I understand that we've been living in the far from ideal world and circumstances. They never will be ideal. And from my personal experience, we need to be creative, we need to be flexible in order to actually survive and be resilient. And that's not an option, that's like necessity to do that. And like COVID was like, again, at least for Ukrainians, we already do not remember about COVID in comparison with current crisis challenges and like needs to fight every day. So that's a good training. We will keep going, and good luck to all of us. Thank you.
Thank you. Some more thinking from your heart. Yes, please. Introduce yourself so people know who you are.
I'm Paul Dessau from Western Australia. Those statistics on the increase, making the treatment more accessible, who'd have thought that more people engage in treatment and that more people get retained in treatment? It's really impressive. I would really like a copy of your slides to take back to Western Australia with me. Your system was far more responsive than my state government's response to the COVID crisis. It's. I actually want to go take those slides to the policymakers in my state and say, look what happened here with this huge COVID outbreak, which we didn't have to experience, and in the midst of a civil war. Thank you.
You will respond, please. You could respond, and then we will take more.
Yeah, sure. Thank you, Paul. I think this is also a good best practices that we can advocate to the policymakers, because in my countries we also use those kind of programmatic data to advocate, to decentralize the treatment and services closer to the people who really need it. Yeah, thank you.
Some more comments? Yes, please.
I'm from Taiwan, and because now Taiwan also face some situation, maybe will face a war, and so thanks for your sharing to let us start to think how can we start to make some prepare. And I also want to ask about how may you please offer us some advice, because we think like some medicine shipping or that may related about some regulation. So how can we discuss with our government to start to do some prepare?
I guess that's very good question to wrap up for all speakers. If you have some ideas how to prepare our governments, like we feel like we are more prepared usually, but more mobilized as a civil society. But what we could do and what you could suggest how to prepare for such crisis from the governmental regulatory area. Maybe we will start like from Theresa, from you, and then no.
Yeah. I would say from what I learned about what happened in the Northern Rivers that people were really responsive, and but they were very afraid of that they were doing things against the law. I think in those situations the government needs to put trust and faith in the practitioners that know what they're doing, that they make decisions, for instance, giving people a month's worth of takeaways if it looks like it's going to be a terrible storm. So I think the government should recognise that those actions save a lot of distress.
I think preparedness from the government is also very important because, no matter COVID pandemic or conflicts or wars, the people who use drugs will not stop using drugs. So it is important to prepare in advance in case of emergency. So how are we going to provide the prevention services, and how do we prevent the treatment interruption for those people who are on treatment? So I think the preparation is very important.
Yes, and I just want to come back to contingency planning, that it's really a good plan to be prepared for any emergencies, for any crisis. And of course, like at the beginning, maybe the community needs to start to do it and involve all the stakeholders, including government organization, because this is like a roadmap for sometimes for specific diseases, sometimes like in general plan to cover like a war or like a COVID. I just, it's like question, answer for your question, but I want to add comment about that, your speech, that all this crisis just give us sometimes like big presence. It's maybe sounds crazy, but I was looking for the increasing line to home delivery OST program, OST treatment. I remember Ukraine case that we just advocated this for maybe, I don't know, for 10 years, it's for true. And the COVID time just give us this very quickly opportunity that sometimes we just need to keep it and to take it in our program and just making the like lessons from this. Thank you.
So I, from my side, watching several crises, I need to say, like, there are very magic words. First we said risk mitigation, but now people saying contingency planning, and the Global Fund understand language business continuation. Now they start planning business continuation and epidemic preparedness. And that's good opportunity with the new proposal and with the speaking with the Global Fund and PEPFAR to start to bring their high-level wise, whatever business counselor to government to start very simple risk assessment and this thinking about the flexibility in legislation. But there are some hints for the government to think already where doctors will be going. If doctors, nurses, hospitals, organizations have evacuation plan, did they agree this? Do they have emergency pack of services data of patients not being taken by occupants because they could use it against for torturing, which happened in occupied territories in Ukraine. So some safe database of the patients for them to have access and to then receive help somewhere. Hotlines, that was the important during the COVID and also during the war, hotlines for clients. And you can't imagine how effective these hotlines for clients existed before work now for advocacy to open, like in 2 weeks when the territory just reoccupied by army. It's just security. It's still bombing mines all over. Patients already have 1,000 requests for OST to reopen the site in this city. And right into the Ministry of Health, we have this request by hotline. It's just amazing. But for the doctors to prepare to the worst, because Ukraine was not prepared. Even though being in war 9 years, we always believed in these populist politicians saying, it will be okay, they just scare us. But we need, and medical systems need to know very simple answers. Where you will go as a staff, where the drug storage will go, who will access to keys, who will have access to data for people to receive treatment somewhere, where people need to call, and do we have the servers out of the country or in the safe place? Very simple question to answer before, even if it's 2 weeks before. It's never too early. And good luck to you. We feel you. Okay. Oh, yeah, one more comment and right in the time.
This conference, everyone is talking about the harm reductions is the human rights, right? Rights to access medicine, rights to access high care is for everyone, especially for the people who use drug and vulnerable population. But it's so heartbreaking to see like sex in Ukraine easily destroyed by the invading war, and also heartbreaking to see Myanmar easily destroyed by the dictator. And also it's heartbreaking to give recommendations to Taiwan to wait, just to wait someone invaded to the country. How should we do that?
That's where we come with solidarity. We all understand that that's turbulence in the world, but we are together, and that's give us strength and give us hopes, and that's the only helping people, working our job, and being together, being connected, asking our friends and colleagues how you are, keep mental health adequate, keep everybody hugged. That's what works in these hard times. Take care. We are strong under some circumstances. Thank you.